We didn't get an LDL cholesterol? We just got a total and an HDL?
Yes.
Okay.
So then these 9 questions were the questions in the chart audit that determined if the patient met the sprint criteria or not. We've just kind of grouped them all into one slide.
So 15.7% met sprint criteria, okay. Yep.
No, 15.7%, that's the average FRS that the system calculated.
Oh, I see. Okay.
We'll be touching on the breakdown shortly.
Okay.
Okay, yeah, here it is. So 19% of the patient population was sprint.
Okay. That's a nice split.
Mm-hmm. And we asked the physicians which medications are currently prescribed for their patient.
Can we just clarify this one a bit? So single antihypertensive pill, does that mean they're just taking, I'm just curious how the question was asked. I just hope that number reflects that should be pills, single antihypertensive pills, and not as opposed to single pill combination.
Right. So we use this question as sort of a gateway. If they selected single pill combination product, then it unhid the follow-up question with all of them listed, and they would select which ones they had chosen. Same thing with the single antihypertensive pill.
Okay.
So then from there, we get into the actual products that were prescribed.
Currently prescribed.
Yes.
And we've got percentage of respondents is the horizontal axis. So 22% of the patients were taking Coversil Plus, is that right?
So 22% of the patients, yes, who were taking it, who were prescribed a combination product.
Okay. All right.
You can see the N went down to 218.
Uh-huh.
And then here's the similar slide for the antihypertensive pills.
So does this mean that there was no one who was getting 2 separate pills? Like there was no one who was getting a separate amlodipine and a separate say valsartan?
So this graph here just shows the aggregate responses across everyone. We didn't look individually at the combinations they were using.
But Swapnil's bringing up a very important point. Many patients are taking, for example, Coversil Plus plus amlodipine. So how did we capture those? Are they captured in both of these 2 graphs? So if they're taking a single pill combination as well as an individual pill?
In that case, it's captured across both of the graphs, yes.
Okay.
So we could show current medications and combine these 2 graphs, but we need to probably select a few treatments to focus in on because we couldn't fit all of this information on one slide.
So I have to kind of challenge your question, your response for a minute, because the N of 419 plus the N of 2 something, what was it? Go back one slide?
218.
18. Isn't that the total in that you're looking at, or is that greater than?
It's slightly less because 5% said no medication.
No, so what I'm saying is that these 2 graphs are mutually exclusive.
No. So for this question here, users could select just single pill combination or the antihypertensive pill or both.
Okay, but we got a total of 603. Go to the next slide. So that's 218 plus 419, so that's Oh, I see. So that's 630, 637 plus the 5%. So 637. So there's a very small number of patients who are taking a combination plus an individual pill.
Yeah, I think it's about maybe 10% if you look at this.
Okay, that's a little surprising, but okay. All right.
And was there no one who was taking two separate antihypertensive pills, so not a combination, but two different pills? Like someone was taking amlodipine and perindopril separately. Was there anyone? There was no one like that?
We'd have to dive deep into the data to look specifically at that, but with regards to this question, users could select as many responses as they wanted. And you can see that this adds up to way more than 100. So there were several patients on more than one pill.
I think it's definitely going to be something interesting to have the number of pills that they're taking, those taking 1, 2, 3.
Yeah.
Number of hypertension medications, and I would propose regrouping by, when you have at least 2 or 3, regrouping by class. The hypertension guidelines recommend certain class combinations.
Sure.
So it'd be interesting to be able to divide it up in terms of those recommendations, what's actually being used. So, for example, globally, ACCB or ARB-CCB or ACE and diuretic.
Right. Okay.
Yeah, and in a couple of slides above, when you have single pills versus combination pills, it will also be more useful as in, one pill alone, 2 pills separately, 2 pills combined, or something like that. Because I don't know right now how many, maybe there were some people who were on 3 pills, right? That doesn't come across so far.
Yeah.
I don't know.
And also be able to eventually be able to separate perhaps the type of diuretic used as well as per the recommendations for the short-acting and long-acting.
Mm-hmm.
Definitely.
Mm-hmm.
Yeah.
Okay, so moving forward, we get into the details. We ask them to indicate the dose and frequency for every medication, so we've summarized that on the following slide. Is everyone okay if I move forward?
Yep.
Okay. So there's more. Frequency, you can see the majority was once a day.
Okay.
Yep.
And then similarly for the single antihypertensive pills, we have the doses broken down. And the frequency again.
One thing in here that's interesting, it's surprising me that so few patients are taking single pill combinations, and we've got so many more patients. Only 200 patients out of 600, only a third of patients were taking SPCs. That's kind of surprising, but there you go. It's interesting data.
Mm-hmm.
And some of these are short-acting, and they're still given only once a day, like hydrochlorothiazide, enalapril, and losartan. Anyway.
Roger, is this sort of in keeping with what you've seen so far from internal reports and things like that?
Yeah.
I don't know the exact numbers, but I mean representatively, yes, in terms of which are the most frequently used, et cetera.
Okay.
Mm-hmm.
Yeah.
It doesn't mean they're doing the right thing, just that this is not uncommon.
Yeah, exactly. Doesn't mean it's right.
Okay, so now we get into the percentage of patients achieving blood pressure targets. And you can see we have the aggregate for the whole program, and then we broke it down based on the patient classification.
Wow.
And you'll note that for the sprint patients, 100% were not at target because the inclusion criteria was that their blood pressure had to be greater than 130 in order to be entered into the program. So automatically they were not at target.
Right, but I was thinking about that when we had that discussion earlier, I guess last week, and so I'm trying to think. So if we think about diabetic patients, for example, or diabetic can't be sprint, uncomplicated patients can't have any sprint criteria. Is that correct? Yeah. Okay.
Uncomplicated patients can have sprint criteria, just not all of them.
Sorry, give me that again.
So the uncomplicated patient could have some of the sprint criteria, but not meet every single point.
Well, none of them, I think, meet all the points. I think in order to qualify for sprint, you had to have just a single criteria.
Yeah.
So I'm trying to think now. What about the patient who came into this study who had a history of vascular disease in the past, but was hypertensive? So their blood pressure was above 140, but they had a history of MI. So that's an important patient. They weren't excluded, right? So I think it's a question of definition here. So there are going to be a number of patients, I think, in that uncomplicated pie who have had vascular events in the past or other things that qualify them for sprint, but at the time they enrolled in the study, their blood pressure was above 130. Follow me? I think we have to look for those guys.
But also it could be the younger patient, they had to be over 50, correct?
Exactly,
50 years of age. So you could have the younger patient that's had a cardiovascular event and would be in the uncomplicated.
Correct. And that would be appropriately in the uncomplicated. But the 50-year-old who's had the previous vascular event but has his blood pressure above 130 at entry wouldn't have been excluded, I don't think.
No, he would have been classified as sprint as long as he met the other criteria, you know, no diabetes, no history of stroke.
Right. So
all
he would
those
have,
details.
Yeah, so that's why I'm thinking there's got to be some patients in there who are at target. So I guess my question is, are any of those patients who have had a vascular event in the past, but are perhaps falling into that uncomplicated pie and actually belong in the sprint pie? You following me?
Because they're controlled?
Right, we want to look at patients who meet all the other sprint criteria. They're over 50. They've had a cardiovascular event, but their blood pressure is less than 130?
But their blood pressure is less than one. Okay, so what I'm trying to say is there are patients probably in this population who meet sprint criteria, meaning that they're over 50 and, for example, they have had a vascular event, or they are over 50 and are in the sprint criteria for any other qualifying criteria that would put them in sprint. But they didn't come in specifically as a sprint patient. In other words, a patient whose blood pressure was greater than 130, was greater than 130. So if their pressure was less than 130, between 120 and 130, then they would be a sprint patient who is not meeting criteria. So the explanation for 100% of sprint patients not at criteria can't be fully, I don't think, can be fully defined by the fact that we wouldn't let them in if they weren't at target. Because, as I say, a patient with a previous vascular event who is over the age of 50, whose blood pressure was 135, would get into the trial, and he would be a patient who would get into the study, but he would be a patient who would be not at target.
And therefore would be classified as uncomplicated. No, would go into the sprint criteria. What I understand is that the sprint patient at target, I mean, not quite at target, but under 130, so not quite at target, would be classified as uncomplicated.
That's correct.
The sprint patient at target would be in the uncomplicated, so we have to be able to separate those.
Exactly. Yes. Is that what you're saying, Dr. Bell?
No, I don't think so. What I'm saying is that anybody who's over 50 and has sprint criteria is a sprint patient.
Okay.
So,
yes.
so I don't think that we can say that 100 that the reason that there is 100% of sprint patients not at target is because that was an entry criteria. Because you could get into as a sprint patient if your blood pressure was below 120. So let's say your blood pressure was, I had it a little bit backwards a minute ago, so I'm going to rephrase it. Let's say your blood pressure was 118 and you had a previous vascular event and you were 55 years old. So I think you would have gotten into this trial. You would have gotten into this study.
As an uncomplicated.
You would classify, you should have been classified as a sprint patient who is at target, as opposed to an uncomplicated patient.
Yes.
Okay.
So the explanation for the 100% of patients meeting sprint criteria being not at target cannot be explained simply on the basis of the fact that other patients were excluded because they weren't.
Okay.
I agree with you. I think we absolutely have
yeah.
to do an analysis in the uncomplicated patients of those that had the sprint criteria, excluding the blood pressure greater than or equal to 130.
Yeah, absolutely.
Yes.
And then we can rework these graphs to see if it's still 100%. That's
right.
really great feedback.
And it is altogether possible that it still is 100%, and I think that really tells a story in itself.
Right.
That none of the patients are achieving what has been shown to be a very significant risk reduction strategy for high-risk patients. Anyways, okay.
Yeah, I agree with Alan. The uncomplicated versus sprint criteria should not take into account what their blood pressure, actual blood pressure is. So it's just based on the clinical criteria.
Exactly. Thank you, Phil.
Okay. So then we get into the physician's perception of the percentage of their patients that were achieving blood pressure targets. If you remember, we asked them, do you believe the patient is achieving targets, yes or no? So we can just focus in on this yellow highlighted number here. This is the percentage of physicians who had a patient that was not at target, but they said they believed they were. So I can just give you a minute to digest this.
We're able to know if that's a specific patient profile or if it's just kind of across the board?
So on the following slides, we do break it down by the classification. But if this is a group you want to dive deeper into, then we can do that too.
This is a nice analysis the way you've got it laid out. It takes a bit of getting your head around it, but it's nice.
Right.
For the patients who are at target, yeah, it's a nice way to lay it out. And you've pointed out the gap.
Yeah, I like it.
Great. Okay, so then we get into the specific patient types. This is the uncomplicated patients.
I don't think it moved forward yet, Jocelyn.
Oh, really? Okay, let me know when you can see the uncomplicated.
I can.
Okay, okay, good. Maybe it's just my computer. Go ahead then.
Okay, and then we go to diabetic, which looks very similar to the uncomplicated. And then the sprint patients, which again, we will reanalyze this taking into account the lower blood pressure. But what you can take away from here is that this educational gap is almost doubled compared to the other two patient groups.
Which may or may not change when we redo the analysis. I would hope that would go down a little, but maybe not.
Right.
Alan and Swapnil, are you surprised by the percentages, or is that
no, I think it makes a lot of sense. Because the diabetes stuff, we have been talking about that for a long time, and you know, PDA and Hypertension Canada, both, or Diabetes Canada and Hypertension Canada have been on the bandwagon of 130 for a long time, but the sprint criteria are new, so I'm not surprised. It just shows our work is cut out.
Yeah.
Yeah, there's no surprise here. Yeah, if anything, I'm surprised that it's not worse than it is.
Mm-hmm.
Then we get into, so if the patient was not at target, the physician was asked if they would intend to change their treatment. You can see the N is 248 for all patients here. So then we have this for all patients and broken down by the groups, but it's really consistent across the groups.
Yeah. And I think it's very interesting to see that 70% plus physicians intend to push their patients who are not at sprint criteria, presumably down to a systolic blood pressure of 120. That takes some getting your head around.
It's a powerful slide. Showing
and the other thing to keep in mind, sorry, Joe, go ahead.
No, keep going, Jocelyn.
The other thing I was going to mention is that these chart audits were completed after they reviewed the clinical update WebEx. So their learnings from that session can be shown here in their management decision.
Right.
Wow.
Because they did their practice profile before they saw the webinar video.
Mm-hmm. Okay, so then for the 66 patients who are not having their treatment intensified, we asked them why.
The most interesting data here is the hypotension is the least common concern, which I would think would have been a much more common concern. Interesting.
Hmm. Okay, so then we asked them what treatment they're going to now prescribe. And you can see the combination product went up a lot. And amongst these 182 patients who are going to have a new treatment prescribed, I've compared what they were on before in the red and what they're planning to receive now. And you can see this increase in the single pill combination.
Nice.
So then we get back into the products and we'll cover the dose and the frequency. So again, this is their new intended prescribed product. This is after seeing the pop-ups with the guideline recommendations saying their patient's not at target.
You know, when we show this to larger audiences, external audiences, including participants, I think that what they intend to prescribe, it might be a little bit better to stick to classes as opposed to individual drugs, considering that this program has been sponsored by Servier and the top two agents are Servier products. It looks bad, even though we did absolutely nothing, to my knowledge, to encourage Servier products be used. I think it's very interesting. It should be heartwarming for our sponsors, but I think it might be misinterpreted by external people seeing this.
Right, absolutely. Classes would be easier.
Is it at all possible to capture whether or not this addition of single pill combinations is a fully new product, or if there's switching involved? I don't think we could capture that, can we? Like, are they just intending to simplify treatment by switching over current, two monotherapies over onto a single pill combination, or if they're adding it on to a monotherapy?
Right.
I don't know if it's at all possible to capture that, but that could be another way of showing it as well. The number of people that intend to, add on a full single pill combination or switch over.
Okay, so if we were looking at the data, we'd want to know patients who are starting a combination, like a novel combination, or patients who are just combining two single agents?
Yes, if they're using it just for pure treatment intensification or for simplification.
Oh, okay.
And then adding something
Sure.
else on. I don't know.
Yeah, we can look into that.
I don't know if that's very interesting. That's interesting, but...
Yeah, no, that is interesting. You know, do you think you can improve this patient's blood pressure control by switching from 2 single pills to a single pill combination? I mean,
we do have data for that.
I suspect it's going to be a relatively small number, but it would be interesting to see if physicians have that perception, that they can do that. They probably can.
Yeah, well, we do have data showing that, I believe, right? Just switching over, simplifying the treatment doesn't improve blood pressure control, so.
Really? Just because of adherence?
Yeah.
Likely, yeah.
Presumably.
Okay, and here are the new intended prescribed single antihypertensive pills.
So if you're going to be breaking them down into classes, when it comes to diuretics, we see the second one there is indapamide. So you may want to break that down into long-acting and short-acting diuretics. Indapamide being long-acting, hydrochlorothiazide being short-acting, chlorthalidone being long-acting.
It is good there to see that they're adding on the long-acting. I mean, that's interesting guidelines-wise.
That is.
When they're capturing the new prescribed, does that include up titration, or is it really a new line on the script?
It does include up titration.
Okay, that's important.
Right.
Do we have enough, is the N high enough that we could actually capture that in terms of, switching, up titration, or adding on a new drug? Because those are really kind of the three, clinical options.
Yeah, absolutely. We can dive into the data and compare those 3 groups.
And I think that's behavior-wise much more important than the actual drugs that they're using, right?
I would agree with that. I think that's a very interesting stat, and that's exactly how I would phrase it, whether it's increasing medication or up titration. Or the third one would be maybe switch to SPC from individual pills.
Yeah, simplification, absolutely.
Yeah.
Okay. Okay, so then you'll review the frequency again. And on to the dose of these single antihypertensive pills. I'm not sure how much we're going to use this data.
No, I think some of this really deep, granular stuff is interesting, but I don't think we're going to be using it much in the presentation.
Right. Okay. And that is it.
Okay.
This is the first one. We're also seeing that this is an intended increase. So here we're seeing ones that they're only using once a day, now going over to considerations of twice a day. So, that's intriguing too in terms of the treatment intensification and changing the doses. Some people seem to be intending to go from once a day to twice a day.
Mm-hmm.
It's not a lot, but you might want to pick up on that somewhere.
Yeah.
Okay, so any other comments or data cuts you'd like us to look into? Thoughts?
Well,
go ahead. No, I was just wondering if it'd be interesting once we go into the 1, 2, and 3, really the treatment options, to see if we can link that at all to blood pressure control. Right? I mean, are the people taking single pill combinations more likely to have the blood pressure control depending on their group, or are the people with 2 or 3 medications more likely to be controlled?
Mm-hmm.
So all the same analysis you have in terms of drug use, but with respect to controlled patients or uncontrolled patients.
Right.
Yeah,
I'd like to
definitely.
see that. Yeah.
I would agree with that too. That's a very, very interesting question. It would certainly be consistent with the data that we know, showing that the SPC patients are more likely to be controlled.
Hopefully we'll find that.
Plus maybe some of the physician demographics to control and lack of control. Again, this is exploratory, but it'll be fun to see that.
Mm-hmm.
Yeah, that is interesting. We just did a similar audit looking at atrial fibrillation management, and female physicians actually were much more likely to be getting their patients appropriately treated.
No, it's very common. Women doctors are better than men doctors. Their patients live longer, patients like them.
Good thing I have a female family physician.
It's just like everything else in the world.
Yeah.
Just very quickly in terms of the demographics, I pulled up the demographics for 2017. Now I don't have experience, but I have with respect to age, which can probably be pretty close. What we're saying, if you have 20 years experience, you're probably over 45. Is that about right?
Yeah, that's right. Start around 25. Yeah.
Okay. Well, that's my cutoff. That's I'm hoping it's about right. So you have about 33% of family medicine general practice physicians that are under 45.
So yeah, that's not far off then. We got a bit of a way towards more experienced physicians.
It's a little skewed, but it's and then between 45 and 54, where you might have a bit of everything, you got 25% of the physicians in there. So it's a big gap. It can really go either way, depending on what cutoff you use. You can increase 10 or 15% easily. So I think there is an overrepresentation, in my opinion, but it's not massive.
No, it's not as massive as I might have thought. So it's about 2/3. It sounds like in the real world, and we got about 82%. But as was pointed out, older physicians are more likely to participate in this for some unknown reason on these things.
Yeah.
So I think you guys have done an excellent job. I think these additional analysis that we've discussed are going to drill down a little further and provide some, and maybe you can just sort of do that and send this material out, and I'll sort of select the slides that are going to be appropriate for the presentation.
Absolutely. So
Yeah.
we need about a week or so.
Right.
We'll pull down the final data on Monday, and then we'll need a week or so to do all these data cuts and put together a report for you, and then we can send that over to you. And then you'll have a week or two to piece that together with the slides you want to cover, and then ideally we have content finalized by the 9th so that we have a week to allow for translation of the slides.
Okay, so the presentation is May the 16th. There are 2 presentations, am I correct?
Yes.
And you're going to have sort of the final slides to me when?
I will shoot for the end of next week.
Okay, that's
the 27th.
great. So that's including getting the new data and doing these additional analyses. Boy, you guys are going to work hard. Okay. All right. As long as I have a week to put the thing together, and then once I put it together, you want it translated. When is it going to be done in French?
The day after, on the 17th.
Right. So how long do you need for that?
For the
Rebecca,
translation.
how long do you think it? Yeah, Caroline.
Yeah, it's usually about a week. I mean, depending on for the additional content we're going to be adding, like Alan, you wanted to do some more of the guidelines. Would it be any reference back to stuff that had initially been done, or?
Yeah. I'm going to cover a lot of the same material that we covered in the initial WebEx. I think that we have to talk about Sprint again. I think we have to talk about the guidelines again. And then I'm going to add a section on this. So it's going to be an abbreviated version of what was originally done. Now, that's already been translated, am I correct?
Correct.
Yes, it has been.
Okay.
And you have those slides, Alan, right? So, or we can resend them to you so you can see them again. Okay, I'll send them. Yeah.
Yeah, and I may add 1 or 2 slides on that data that Roger provided for me on other estimates that we have of blood pressure control.
Okay.
And then the rest is going to be the data that we're looking at, a selection of those slides.
Okay. No, that shouldn't be a problem at all. I'm trying to think. Our translator is on holiday until May 7th. So if we can get it to her at the start of that week to work on it, that would be great. If we're finding that we're cutting it a little close, CDC on your end, do you think you could handle any of the translation for the actual slides that you're putting together here?
I think we can probably do it. We can figure out another angle, Rebecca, through our translation team.
Okay.
She'll have another idea for that. So, and we also should consider just some time to brief Dr. Fournier, who's doing the French WebEx. So it would be good if Alan could, you know, at least a few days before this happens to go through everything with Carl, sort of so that he's very comfortable, obviously, with what he's presenting.
Okay, so my plan is going to be the weekend of the 5th and 6th of May is when I'll put this presentation together.
Okay.
And I'll get it to you for the 7th.
Okay.
And then I can go through it in English with Carl one day that week.
In English, yeah, okay, that's fine.
Yeah.
So we can see when he's free that week. We'll set something up.
Yeah.
Okay.
Or if you guys want to meet with him and just go through this data, I'm sure that once he sees the slides I put together, it shouldn't be much of an issue for him. I'm sure he'll be fine. But whatever, if we have to do it, we can.
Okay.
And I would think, you know, maybe the 8th or something. I've got a really nasty week that week.
Oh, no. Yeah, so do I. Okay, so slides from Alan to us for translation. Okay. Oh, and we should probably show those to Ross and Swapnil also, right, before those go to translation. So maybe on Monday the 7th.
Okay.
Swapnil, we can keep an eye out for that. Okay.
Sounds good.
Perfect.
All right.
And how many people are signed up? Like, have people actually signed up to the WebExes? Andrew, do you know offhand? I'm not sure if you know, but.
I don't know the numbers for each event. I could look that up for you. But as part of the program, everyone has to sign up for one of the 3 events, the 2 in English and 1 in French.
Okay.
We did have, I think, one user who said that they couldn't actually attend any of the events due to some scheduling conflicts, and we actually were wondering, is it possible for us to record the WebExes just for these very extreme cases? There shouldn't be many, maybe just 1 or 2 doctors. So that I
would like to have them recorded, yes, definitely. I think it's good. Yes, definitely, yeah.
Audio only.
Audio only?
Sure.
Okay, but yeah, it is okay to share the content.
When I say audio only, I mean audio plus the slides, not my face speaking.
Well, yeah, like the video recording will only capture what's shown on WebEx, so you could disable the webcam if you don't want to have, like, I guess.
I see.
Yeah.
Oh, I didn't realize these were going to be done on webcam. Okay, that's fine. No, that's fine. I mean, am I going to be doing these from home or in a studio?
I don't think it really matters as long as your connection is very stable. So, I mean, you're more than welcome to do it at home as long as your internet's, you have a good internet speed and I guess a secure setup
like
there.
Usually works.
Yeah. But we'll be on hand just to make sure people are able to connect okay, and if anyone's having difficulty, I think 1 or 2 of us will be there just to connect with them privately, just to get them onto the WebEx and make sure everyone can watch and listen.
Okay. And Carl will need some sort of a briefing on how to host the WebEx as well, for sure, I would imagine. So.
Sure, we can connect with them a few days prior and just do that. But we'll be hosting the WebExes. We'll just be kind of passing the presentation ball over to Dr. Bell and Dr. Fournier, and they could take it over from there, and we'll just be monitoring Yeah.
Okay. Sure, and then I have absolutely no objection to recording.
Okay, cool. So it is okay then to share the content with the one doctor that won't be able to attend then?
Yeah.
Okay, perfect.
Okay, you're going to start sending out reminders to make sure that people are going to be available for these things, right?
Pardon me, Dr. Bell?
You're going to send out reminders to ensure people are signed up, and okay. And we're going to be doing it twice on the 16th, once at 6, once at 8:30, correct?
That's correct.
And it's going to last approximately 1 hour?
Should be around there, yeah. Just to get through all the content and just have a little bit of time for questions if there are any.
Okay. So how many slides is that? We should think, pre-think about this. So
I'll figure it out. I'm
30 to 40.
The question is there also going to be any other component besides me speaking? Will there be any follow-up, you know, you're going to receive your check or anything like that, or just communicate that to them by mail?
That's something I guess we could discuss. I don't think there was any plans to mention that during the WebEx, but
right. So I was just thinking that was the only logistical issue that I could think was remaining.
Right.
Well, there's also the program evaluation, which we're planning to have them do on VivoMap after the webinar.
Okay, so if
we will send out a communication saying thanks for attending the webinar. You can now log on to VivoMap and do the program, the exit survey. Yeah.
Okay, so if you could send me a slide when you're sending me these results slides, just including that sort of thing, and I'll just mention it.
Sure.
Sure.
Is it possible to share this interim analysis? So just to read through it to make sure there's nothing else I've missed?
Absolutely. Yeah, I can send it out to everyone.
Sure, no problem from my end. And maybe John would like to see it too. I know he couldn't attend today, but it would be great if you could show him that, Roger.
Absolutely. I can run through that with him and discuss some of the other analyses we were wanting to do.
Okay, great.
Yeah, and feel free to reach out to me next week if there's anything else you want us to look into.
Okay.
Have we decided that we don't want to write a paper or an abstract and submit this somewhere?
I think there was a decision not to.
Especially because we didn't go through for the ethical review in the beginning.
Right.
Yeah, we didn't do any of that stuff, but, you know, I suspect if you
probably
wrote it up and submitted it, you'd get it.
Yeah, you probably still could. Yeah.
We've certainly done it other times where we didn't go through the ethical review process. I think this data is pretty powerful to show intent to change. So that's generally well accepted. As you know, Dr. Bell, with other programs we've done, it's generally well accepted by conferences for either poster or oral presentation.
Mm-hmm. Yeah, I'm sure that if we were so motivated, it would be totally doable.
Mm-hmm.
Okay.
Great. That was great. Thank you so much.
Thank you.
Yeah, you guys have done a fantastic job. Thank you.
Yeah,
thank you. It was really interesting.
Yeah, Jocelyn, great job presenting that. Well done.
Thank
you very much, Jocelyn. Super. Okay, and we have a plan to move forward for the WebEx preparation, so that sounds great. So fantastic. Thank you so much.
Great. Right on time.
Good day.
Have a great day, everyone.
Take care.
Bye-bye.
Bye-bye.
Bye.
Bye-bye.